Everybody, welcome to today's special event. We have a very special VMR that we're bringing to you. We have a clinical case, a VMR with POCUS imaging. So we'll kick things off with the first case today, and then we'll follow up with additional cases next week. Actually, we have Dr. Sanjay Patel, who's here with us today. He'll be also presenting a case next week. The format will be the regular VMR with a clinical case, but what we'll do is augment it with clinical imaging. So the imaging will be point-of-care ultrasound images, and don't fret and don't worry if you don't or are new to ultrasound. We will break down the basics, so you will at least leave learning some element of point-of-care ultrasound and how it really moves the needle in the clinical reasoning process. But before we get underway, I'll ask our discussants, Madalena and Deborah, to introduce themselves. So Madalena, go ahead.
Yeah, hello everyone. My name is Madalena Conti. I'm a medical student in New York, but taking a year off, so I'm currently in California. And I am so excited to learn more about point-of-care ultrasound. I want to just give a huge shout out and thank you to Ravi for organizing all of this, and to all the future speakers. I know this is going to be so valuable to me and to so many other people. And I'm also really excited to discuss with Deborah. Deborah, do you want to introduce yourself?
Hi, everyone, and welcome to the section. We are really excited. I will be here discussing, so if I need any help or if I get any nervous, I will look in the chat. I'm a lawyer, so I'm not a doctor yet. So if I say something wrong, please forgive me. And yeah, let's go forward.
All right, excellent. And our scribes today, Shema and Promise. Shema and Promise, would you like to introduce yourselves as well?
I think Shema can't speak. She is in the library.
Oh, okay. So Shema is from Berlin, Germany, and also a medical student, and will be helping with scribing. And Promise.
Hi everyone, my name is Promise. I am a third-year medical student. I just finished my first rotation, and I'm super excited to be back and learn about POCUS because I feel that it's not emphasized enough in medical education, and so I would love to be here and learn more.
All right, great. So we will launch the whiteboard, and before that, I'll just mention about myself. So I'm Ravi, one of the CPS team members, and a long-time learner of POCUS. Still haven't grasped enough of POCUS, but I think I'm able to at least introduce this case today and get things kickstarted today with a case I had on the floor. So the chief complaint. We have a 77-year-old male who was admitted with a right hip fracture and is supposed to go to the OR later in the day, but then we are called to the bedside for acute dyspnea and sudden onset of altered mental status. And the dyspnea occurred over an hour, and the altered mental status has been brewing since the last few hours. And I'll stop there. Deborah, you want to tackle the first aliquot?
Yeah. So 70-year-old male that with a fracture and dyspnea. So thinking about dyspnea first, that can be like from pulmonary, cardiology, or hematology causes. I could think about that. And AMS, we have the pneumonic mist, that is metabolic infection, exposure or toxins, and we have and then have the situation about the rib fracture. I can think about a PE, a fat embolus, and that can cross my mind about the dyspnea. And let me think. Yeah, I think that this will be my first thoughts, and ask more questions and see about some chest pains the patient is feeling, and check more about this AMS, and check the patient, the vitals, the signs to make the patient stable. I think that's where I would go for it.
Yeah, I think Deborah, you hit on so many important points, and I love how with dyspnea, even though it can be caused by so many different things, hematologic, pulmonary, cardiac causes, you focused in on the cardiac and pulmonary systems. Because of the other chief concern we have, because of the dyspnea and ultramental status, but also because of the high morbidity associated with dyspnea from those two organ systems. I think what's also standing out to me here is the acute time course. So the acute dyspnea and ultramental status developed within 1 hour. So for me here, I think I'm more focusing on management, and I want to make sure, is their airway protected? Do we need to intubate in any situations? And Deborah so beautifully walked through the missed mnemonic, the metabolic infection, structural toxin. And even though there's a lot in each of those buckets, I think because we have dyspnea, I'm really want to be interested in what is the O2 saturation, is there hypoxemia here? Do we need to get an EKG, an ABG, things like that? But Deborah, you so beautifully kind of started this case off for us. So yeah, that's what I'm thinking right now.
Absolutely incredible. Great job, Deborah. And this is Deborah's first time discussing. So great. I love missed mnemonic. I just used it yesterday on rounds. So just moving forward with the case. So he has a past medical history of heart failure with preserved ejection fraction, diabetes mellitus type 2, and also hypertension. So the story is he was admitted 1 day ago for a fall downstairs. He was alert and oriented during the admission process and didn't have any ounce of dyspnea. And he just complained of pain in the right hip. There was no associated chest pain, no fever, no cough, no congestion, no abdominal pain on admission. The past medical history as stated, social history, he is a retired school bus driver. Family history, diabetes and high blood pressure. And no health-related behaviors, no allergies at all. The medications that he's on is Procardia for high blood pressure, lisinopril also for high blood pressure, and he takes insulin for his diabetes. And we'll move to the physical exam. So his temperature is 37.9, heart rate 107, blood pressure 154/89, respiratory rate 22, and oxygen saturation 88% on room air. And generally he's appearing not awake, but when you move him, he is moaning. On HENT, he has JVP. Respiratory, there are prominent crackles bilaterally and some wheezing. Cardiovascular, normal rate, regular rhythm, no murmurs. And regards to his abdomen, he has a distended abdomen. And when palpated, he is moaning. Tympanic to percussion, but there is dullness around the umbilical area. And there's more pain and moaning around the or inferior to the umbilical area. Extremities. Both legs are swollen and they're similar. And on the right side, he has a shorter leg and is outwardly rotated. And Nero is pretty much asleep, but wakes up and moans to any sort of stimuli. And I'll stop right there.
I think I can talk about the past medical history and medication, and maybe Madeline about the exam. So like this hyponatremia can explain the ultramental stats and make me think about that. And besides that, the patient has diabetes. I will check if the patient is controlling the diabetes, because that can explain the ultramental stats too. And let me see what else. And I will check if that have ever happened before. And another thing, the blood pressure that is a little bit higher, and the patient is hypertensive. So check if the patient is controlling the hypertension too, because a lot of these patients can go to the emergency room for not being controlling the hypertension. And let me see what else. Yeah, I think until here, and yeah, take care of the saturation. No, put a nasal cannula and check again the saturation, do an ABG. So what do you think, Madalena?
Yeah, Deborah, I think you hit on some really important points here. I think you highlighted the heart failure in the past medical history, the diabetes, and you pointed out what also stood out to me as one of the really concerning parts of the vitals, which is the hypoxemia we see here, 88% on room air. That also stood out to me. So we got a lot of data to sift through in the physical exam. And one of the reasons why I think it was so important, you mentioned that heart failure in the history, is that we do see signs consistent with heart failure in the exam. So we see the elevated jugular venous pressure, we see prominent bilateral basal crackles. Do we see edema both legs? Yeah, so we see bilateral leg edema as well. So to me, those signs can point to a volume overload picture, perhaps from heart failure. I think I believe I've watched a video that Reza has made about how to approach hypoxemia, which I find really helpful. So you can take it from just at a high level, you think of oxygen acquisition from the environment, then the journey that oxygen takes to the alveoli, and then diffusion of oxygen from the alveoli into the bloodstream. And any point along that journey, if there's a pathology in any point in that can lead to hypoxemia. So that's kind of a helpful way to think through all the different causes. In terms of kind of where we can narrow in on that journey, what stood out to me is the prominent crackles. So the prominent crackles, that to me means the alveoli are potentially filled with some kind of substance. And so you can think of as this, is it filled with water from, cardiogenic pulmonary edema or non-cardiogenic pulmonary edema? Is it filled with white blood cells? So from pneumonia, aspiration pneumonitis, is it filled with red blood cells from diffuse alveolar hemorrhage? So those are ways that you can think of what are the different things filling the substances. And with this history of heart failure and these signs consistent on physical exam, I am thinking that potentially water could be filling those alveoli. Another interesting aspect of the physical exam, actually, Deborah, I wanted to hear what you thought of it. It's the abdominal exam, the distended abdomen. What did you think about that?
Wait, distended abdomen, palpation, tympanic progression, doesn't pain for umbilical area. So yeah, maybe as the patient suffer like the rib fracture, maybe thinking about like the fat emboli and see if the patient, how long time is this pain, if it's acute, not a chronic, if could be like something that is distending, or water or gas. Let me see what else. Yeah, and then think about the pain that is in the umbilical. Think about what can be causing that area. I think that's where I would go for it.
Yeah, I think those are really good thoughts. I see that Shema put in the chat kind of a helpful way to think of abdominal distension in the different kind of phases of matter. So is this a solid, is this a liquid, or is this a gas causing this distension? Shema also like put in the chat how like right-sided heart failure, right-sided heart failure can cause can lead to portal hypertension and ascites, which could potentially cause the abdominal distension. I'm also wondering, dullness over the periumbilical area, is there some kind of urinary retention here? Do we want to put a Foley in? So those are my thoughts on the physical exam, but this is kind of a POCUS session. So Deborah, any thoughts of like where you would want to ultrasound at this point?
Yeah, I think probably the abdomen, and do like a X-ray of the chest. I think that's where, besides the ultrasound of the abdomen, that's what I will be looking for.
Incredible logic. So just imagine you're at the side of the bed of this patient and you're swelling bullets, and you're like, okay, what could I use to figure out what's going on? Yes, order the X-ray, but X-ray is taking a long time. But you're like, I was going to ask that question. If you could get 2 images using an ultrasound, what would you get? So here we'll do a timeout. I'm going to share screen and I'm going to give you the images, and then we'll sort of do a quick run through what's abnormal and normal. So we'll pause a second, and I'm going to get rid of the whiteboard, and then we shall share. So, and here we go. So this is an image of the bladder. Any thoughts about this? Somebody had mentioned the abdomen. So the moment we put the ultrasound on, we saw this.
So it appears very distended. I guess if we're using kind of some ultrasound terms, it would be more hypoechoic or even anechoic. But we can talk about that if I'm using those words correctly. But it seems very distended, and perhaps maybe some urinary retention we're seeing.
Absolutely right. So yes, the darkness that you're seeing is fluid. So any sort of fluid is usually anechoic. It's not going to reflect back sound, because ultrasound is images obtained by sound. And what you're seeing around the area of darkness is a hyperechoic. So you use the terms very nicely. So you have the terminology down. And this to me immediately meant that the patient was retaining. I don't know why, but the patient likely had BPH. So this was part of the puzzle. Now we'll put the probe on the lung. And before I mention anything, does this seem familiar, or do you know what we're looking at?
Deborah, does anything jump out to you?
So that's okay. I was just going to give you the opportunity. Madalena did a great job with the bladder. So this is looking at one of the lungs. I wasn't going to put all the different zones down, but we usually do take ultrasound pictures in 4 quadrants of the lungs. It could be upper lobe and then lower lobe, but around the mid-axillary line. So this picture that you see here at the top here, I don't know if you see my cursor, but this is the pleural line, and this is hyperechoic, and you see it crawling or shimmering. So this usually means it's moving and it's intact, so there's no pneumothorax. But then you see this comet tail configuration, which is very nice. So this is pathologic and something called a B line. So just keep this image in mind. And we're seeing these sort of vertical comet tails or sun rays, and we're seeing many of them as the patient's taking a deep breath. Looking at, so a lot of times when I do actually do POCUS with students, and they really enjoy it. And at the beginning, when I started learning, what are we exactly looking at? And I love this slide, and I've been using it. we're looking at all sorts of different gray contrasts. So fluid here, anechoic, like Madalena mentioned. Hypoechoic is this dark gray, and it could be tissue like renal cortex, skeletal muscle. Then you have isoechoic tissue, which will be something along the lines of liver, spleen, so it'll be a lighter gray. Then you'll have hyperechoic or interfaces like diaphragm, like renal calyx, like what we saw. Like what we saw in the pleura here. So very bright. So an interface like pleura, pericardium, peritoneum, and so on, all around the bladder. So they would be hyperechoic. And we may actually get reflection with anything like air, bone, stone. And I remember for step 1, when you have a gallstone, they always mention acoustic shadowing behind the gallstone. So this is what it is in a depiction. So I took this slide or sets of slides from teachim.org. I think they do a very good job in trying to show how to get these images and what exactly we're looking at. So this image depicts when you put the ultrasound down, you want this dot, the setting of the ultrasound on the left side. On the right side would be cardiac. On the left side would be like gastroenterological windows or images, lung windows, and so on. So on the ultrasound, when you go to look at it, it can be intimidating, but there's a setting, lung, abdomen, vascular, and so on. So you want the setting first on this side. This is the patient's head, the dot on the ultrasound probe towards the head, and then you get this nice sort of conical image. And this is different than the other image, right? So the other image was these vertical tails, and they're all shimmering like cosmic rays. But this one is more what I think about is a stepladder. You have one line here, you have one line here, you have one line here. And this structure is the pleura, right? Pleural line. This here, dark shadow, is our ribs. So some people call it bat wing. You see dark here, wing, and then the body of the bat in the middle. Rib shadow, rib shadow. And then what you may see are these reverberations. So you see the pleural line here, it's being echoed all the way down. So you don't actually see lung, you actually see reverberations of the pleura. So you see this line here echoing down here, down here, down here. And this depicts A lines, which should be normal lung findings. But then after we discuss, I'm going to ask Dr. Dansel, Dr. Patel, who are experts in POCUS. They may have some pearls to share with us. So these are A lines, which is normal, and we're seeing about 3 of them here. This is what we saw for the lung, right? So this is completely different. This is sort of, it turned on its side. So instead of having horizontal lines, we have these vertical lines. So what exactly is this? We have a pleural line here. We have B lines here. And how do you designate B lines? There is a criteria. So you can have greater than or 3 in a rib space. It moves with respirations and it travels from the top to the bottom of your screen. So this meets the criteria for B lines. Now, what's the differential? So you might say like, okay, how does this move the needle forward in my reasoning? I've come up with this beautiful differential, Madalena and Deborah, that there's something in the lung, which could be PE, fat embolism, pulmonary edema, and so on, and urinary retention. But just focusing on the lungs, if it's seen focally, but I'm going to tell you this was seen throughout all the lung fields. But if it's seen in a certain area, this differential could be pneumonia, atelectasis, malignancy, or infarct. And then if seen diffusely, this could be pulmonary edema, ARDS, ILD, or multifocal pneumonia. Now you might ask, how do I figure out between the 4? If it's this B line is telling me these 4 different things, how do I figure it out? You use the clinical context. So what is the patient telling you? If you have a pneumonia, a patient may be febrile, cough, congestion, hypoxemia, tachycardia, white count, so on. So the picture will be more of a toxic presentation. This patient has a certain other presentation. And I'll stop right there. And what I will want you to do is then take what you've learned from this and probably make your final diagnosis. Okay, we can bring up the whiteboard again. Deborah, you want to start?
Yeah, I think thank you, Ravi. I never have saw like the lines like that. I think in this patient maybe could be edema that could be causing, and as the patient has a heart failure, oh, we can think maybe it could be a congestion, or can be, as we said about the fat emboli or the B. I think that will be the diagnosis that I will be focusing on. How about you, Madalena?
Yeah, it's interesting. I'm actually, my reflex response is that this is, cardiogenic pulmonary edema. We see the diffuse B lines here. We see a lot of the aspects of the physical exam are consistent with that. The crackles, the, this distended abdomen. And we talked about how heart failure can lead to ascites, the bilateral leg edema. But you mentioned a really good point, and a lot of people in the chat have also mentioned this, the history of the right hip fracture, and then this, very sudden acute presentation of dyspnea is there. People have mentioned like a fat embolism that could be leading to this. So those are two in my mind, and maybe we can talk through how we would make progress on both of those. I'm just kind of reviewing the whiteboard to see if I'm missing anything. But yeah, my reflex response was the cardiogenic pulmonary edema, but the right hip fracture and kind of this really acute presentation is making me consider the kind of the fat embolism picture.
All right, absolutely phenomenal. I think putting it together, that the patient actually, what happened was the patient actually had acute urinary retention, was supposed to be on a prostate agent and wasn't continued, and maybe developed acute urinary retention, but then also the process of the hip fracture probably added to it. So with the acute urinary retention, developed altered mental status, something called cystocerebral syndrome, being very technical if you want to be. And then the patient having heart failure with preserved ejection fraction was also NPO after midnight for this procedure and was put on fluids, and then went into acute pulmonary edema. And as Dr. Patel mentions in the chat, that this being diffuse, as on the right side when we saw the image, it was prominent. So the four differentials were the ARDS, ILD, pneumonia, and pulmonary edema. So this, you had it in your differential, which is beautiful, and this definitely moved us. We didn't have an X-ray, we didn't have anything else to go on, but we had the physical findings, we had the history, the acute onset, the fluids that were running overnight, JVP, crackles, and I didn't give the labs, but a proBNP came back and it was 5,000, lo and behold. So putting in a catheter alleviated the abdominal distension, and a couple of hours he woke up. And then meanwhile, we diuresed and his congestion improved, and eventually he went for his surgery a day later. I'm going to share the screen for a second, but what was very interesting is the schema that Deborah had mentioned with altered mental status. So I actually did pull it up. I use an iPad on rounds, and looking down here, guess what's down here? Urinary retention. I was like, whoa, it's in the schema. So yes, we've been baffled before with patients developing acute mental status, and it's something definitely to put on your radar screen and also entertain as a diagnosis. And then a sort of a mechanism you can look up for cystocerebral syndrome or acute urinary retention. There's bladder wall distension, adrenergic receptor activation, locus coeruleus activation, hyperarousal. There's also the advanced stage, cognitive impairment, all contributing and adding to encephalopathy. And then the bladder outlet obstruction, somebody, I think Max had mentioned in the chat something about inflammation. You could potentially over time get urinary tract infection, which will cause neuroinflammation, neurotransmitter dysfunction, also adding fuel to the fire, encephalopathy, or this cystocerebral syndrome. So I'll stop share right there. Any reflections? Deborah and Madalena did a fantastic job. You're right on point. You're right there.
Yeah, thank you, Ravi, for the case. I think we always use the mixed mnemonic, and I never thought about the urinary retention. Actually, I saw the mnemonic on the website. So that's, I think, one of the things that I'll keep in my mind. And thank you for all the explanation. I think was really clear. I think I will watch again so I can take notes. And yeah, I think that's it.
Yeah, I think my reflections are this was such a helpful case to go through, because actually just reflecting on the final diagnosis, so it seems like the ultramental status was from the urinary retention, but the dyspnea was primarily driven by this basically like heart failure exacerbation. So there's kind of like two different things going on. But it was really helpful to walk through, the approach, the missed mnemonic to ultramental status. Ravi, your teaching of just kind of the basics of ultrasound, but then also the differential for B lines was really helpful to me, because in my learning, I kind of associate B lines with pulmonary edema, but there's clearly so much of a wider differential. So that was really helpful. And then your point that to make those distinctions between the differentials, really wanting to use the clinical context. So I learned so much and definitely want to, learn more about the utilities of POCUS.
Awesome. I'm just very proud of both of your performance and discussion today. Is a fantastic job. We have actually some minutes. I'm going to ask Dr. Dancel, who is a fantastic teacher all across this nation of POCUS at most of the major national meetings, if she could just comment and give us a few pearls of wisdom.
You guys were really great in the chat and in talking about, some of you had maybe not heard of POCUS, or maybe it's been a while since you've talked about POCUS, but there were a lot of really great thoughts. Very, very classic for folks to come in with hip fracture and get pain medicines, in particular opioid pain medicines that cause urinary retention. And so when we got to the distended abdomen, very quickly there was questions about whether this was a distended bladder or if this was ascites. Both really, really good questions for point of care ultrasound, because fluid is the easiest thing to see on POCUS. And so immediately, Ravi found this distended bladder and was able to fix that problem. And then this happens so classically when folks come in and they don't urinate and then they get fluids, right? And then you have somebody who has already a history of heart failure, now getting fluids. The differential diagnosis in the chat was also really great in terms of what was the hypoxia all about. I mentioned something called the Blue Protocol, which is something you all can look at. This actually was sort of created in 2008, so quite a while ago, by a French intensivist by the name of Lichtenstein. So if you look up Lichtenstein in the original Blue Protocol, you can learn about A lines being sort of the normal pattern that you should see, B lines being exactly how Ravi had described them, and the excellent differential diagnosis. And then what does consolidation look like? What does effusion look like? Again, the easiest thing to see on ultrasound is fluid, right? All these things that you can see. And then we talked a little bit about PE. So PE in itself on POCUS, you can see focal B lines. Rarely, you can actually also see a wedge infarct. Very, very rare, but very telling when you do see that. But the nice thing is that the Blue Protocol also involves DVT. So you go and you look at the legs as well. A little bit difficult to do if someone just had a fracture, because that can be somewhat painful. But certainly you can flesh out your diagnosis your differential diagnosis a little bit better by employing those POCUS exams. Sanjay, did you have anything else? He's on service right now. It's sort of in and out.
Sorry. No, I wonderful learning points, Ravi, and wonderful discussion in the chat and good points there. Ria, I know I wrote in the chat there. I think the other thing to remember is, we kind of have this conglomeration of symptoms, and, at least with the dyspnea, we kind of point towards cardiopulmonary, but then we have this distended bladder. So when we talk about POCUS, it's really thinking about all of the different pieces of information and how do they integrate together. So we had these lung findings that explain the dyspnea, but then we have this distended bladder, and so kind of thinking, how do those two findings integrate? What's the common link? Because as internists, that is our constant diagnostic struggle. Is it one thing that explains everything, or are there multiple things going on at the same time? So just remembering that you aren't necessarily going to get the exact diagnosis just by looking at something, but you have to take all of the different findings together and integrate how they fit together.
Absolutely wonderful. We're really lucky to have both of you on today, and really looking forward to the collaboration in the next few weeks, as Dr. Dansel will be back on at the end of the month to bring a case and also do teaching. And Dr. Patel actually will be presenting a case next week, and we'll run it in the similar kind of a format. But we'll end with teaching points. Promise, take it away.
Hi, everyone. Thank you so much for such an incredible learning session. Thank you, Deborah and Madalena's discussion. I learned so much. I had a really nice review of POCUS and relearned a lot of terminologies. So we started with an elderly man, 77 years old, presenting with acute dyspnea and altered mental status, and he was preparing for a right hip fracture surgery. So Madalena pointed out that it's important to note the acute course timeline here, and also Deborah talked about missed mnemonics regarding the dyspnea causes and thinking about the cardiopulmonary causes of dyspnea. And then we found out that this patient has a past medical history of diabetes, hypertension, and heart failure. So that kind of drives us more towards a cardiopulmonary cause. And when we looked at his exam findings, something that stood out were the prominent crackles bilaterally, a distended abdomen, and then in the legs, kind of confirming the fracture. And especially important was we noted that he was very hypoxemic. And so Madalena talked about how if you have crackles and hypoxemia, we could kind of think about perhaps the alveoli is filled with a lot of stuff, and that may be fluid overload. And at that point, we talked about what we could do in the bedside with this patient, and with ultrasound, we could do a bladder and a lungs, and to quickly kind of see what's going on and narrow down our differential. And so with this patient, we saw the bladder is very distended, and here Ravi gave us a very good teaching session on when you see a very distended bladder, you will see that your entire screen is pretty much like filled with like mostly anechoic fluids, and then a little bit of hyperechoic, showing the tissues on the side. And in the lungs, we saw that it was, we got a very nice teaching session on the hyperechoic pleural lines, and then we also learned about the A lines and the B lines, which the A lines would be horizontal and the B lines are vertical. And there's a specific criteria, which I definitely have to go back and review that. And then we talked about the main takeaway with the B lines would be we want to see if it's focal or if it's diffuse, because that would really change our differential. So if it's focal, we would think about pneumonia, atelectasis, malignancy, and infarction. And if it's diffuse, then we would think about pulmonary edema, ARDS, interstitial lung disease, or a multifocal pneumonia. And all of these, like our clinical picture, the patient's presentation will help us guide our differential and kind of like our next steps with that. And then we found out that for this patient, his acute mental status was due to the urinary retention, and that activates the adrenergic receptors and also locus coeruleus, which is the thing that makes a lot of norepinephrine, and that leads to hyperarousal. And then combined with this patient's advanced age, that those two factors together likely led to this acute course of encephalopathy and delirium, the altered mental status change. Thank you so much for everyone's participation. Yeah.
Thank you, Promise. That was great. It's great to have you back on VMR again. So that's it, everybody. Have a great Tuesday. Come back tomorrow for VMR with Stephanie and Zavin. So have a good Tuesday afternoon. Take care. Bye.